Okay, thank you for the introduction. Indeed, I'll be presenting you our study on an international multidisciplinary Delphi-based consensus definition of recurrence of Dupuytren's treatment. And some of the authors we have previously worked as a consultant, but I don't think it's related at all to this study. As you all know, and we've talked about it for 2 days now almost, is that there's many different outcome measures and there's not one that's important as a single outcome measure. So you want to measure a contracture correction, maybe early after outcome, complication rates are important outcome measures, some measure of hand function, maybe a return to work outcome measure, and recurrence is also one of the important things that you want to measure if you're comparing outcomes. And except for a few comparative studies where there's a direct comparison, much of what we know about recurrence for different treatments comes from case series where they report recurrence rates, and the question then is, can you compare these recurrence rates? And what we published in 2013 is that if you dig into the literature, you can find more than 40 different definitions of what a recurrence after Dupuytren's disease is. And even worse is that if you apply these different definitions to your single data set, you can basically tweak your reported recurrence rate anywhere between what we found between 2 and 86% just by picking a different definition of recurrence. So if we just let everybody do that, then I think we're in trouble, except if we do a really comparative study. But then again, even if you want to compare randomized controlled trials, it would be nice if there's some comparability. So the aim of this study was to see if we could come up with a consensus definition, one universal definition for the recurrence of Dupuytren's disease after treatment. And we performed the Delphi study, and maybe many of you know these Delphi studies or have been involved in them. It's a way of systematically exploring the opinion of a group of experts, and the group of experts provide feedback, and it's anonymously being reported back to the other experts, and the idea is that through this kind of communication you work towards a consensus and you have kind of a threshold for consensus. We selected experts based on the contribution in the research field of Dupuytren's disease, mostly senior authors or first authors of papers in this field. We invited 43 experts and 21 were willing to participate, and I think you'll agree that this is quite an extinguished group with many of them, I think, also in this room right now. We needed 5 rounds in total to come up with a consensus, in which the 5th round was the approval of the definition that we constructed. And the way that we approached this is that we asked them questions around 4 different dimensions, basically. And I'll explain the dimensions and also explain the consensus that was achieved. So the first thing that we asked questions about to the expert was about the location of the recurrence, and that basically deals with the question how to distinguish recurrence from disease extension, if you want to distinguish that in your definition, if you want to include all joints, or maybe what we initially did in our trial, only look at, for example, 1 digit for statistical reasons. And the consensus was that all treated joints should be evaluated. The second issue was whether this definition should be based on the presence of nodules, cords, or an angular-based contracture type of measure. And consensus was that it should be a contracture, so an angular-based measure, and that the presence of nodules and cords should be excluded. This was actually the biggest discussion point, and I'll come back to that in a minute. After it was decided that it should be an angular measurement, the next step was that it was defined that 20 degrees would be the threshold for yes or no recurrence. Then the third question was, when should this be measured? What do you take as a baseline and what as the time to measure your recurrence? And consensus was that baseline should not be maybe perioperatively as sometimes being performed, but 6 weeks post-treatment. as kind of a baseline, and then you compare it to 1 year follow-up. And finally, it was agreed upon that things like patient-reported recurrence, or maybe percentage of resurgeries was not included in this definition. So if you combine all this, you can construct a definition which is that recurrence is any increase in joint contracture in a treated joint of at least 20 degrees at 1 year post-treatment compared to 6 weeks post-treatment. See some pictures being taken. It was recommended by a number of the experts that it would be very valuable to repeat it over time, because we don't really understand yet how recurrence evolves over time, and if that's similar between between different treatments, and that it would also be valuable in addition to report recurrence for individual treated joints, for example, MCP and PRP joints. So how to apply this in practice? This is an example, hypothetical example, patient with a left hand involved, MCP 4 and 5. You have your pre-treatment, and you have the 6 weeks and the 1 year, and there's one recurrence in this hypothetical example. And you can do that for a number of different patients and different hands. You count the number of joints where there's a threshold above 20 degrees. So in this example would be 5 out of 14 joints, which would give you a recurrence rate of 36%. As a discussion, as I mentioned before, experts opposed to including nodules and cords, and the main reason was that they by itself are no indication for surgery, and that many minimal invasive techniques do not remove these nodules and cords, and that although the previous speaker, for example, did show a measure, that there's not really generally accepted measures yet of these nodules and cords. So the take-home message would be that to allow comparison, we propose this well-defined recurrence rate as the minimal to report in future studies, and I think that's an important addition. What we learned, I think, from the consensus and also from the trials that we do in Rotterdam, is that I think it's impossible to really catch all the finer details of recurrence in one measure. But if we would at least all report this measure in addition maybe to some other ones within each study, we have some kind of a comparison between groups. So thank you for your attention.